Hi there, my name is Pat Snyder, and I'm going to be teaching today about medications that you need to avoid if you are caregiving for a dementia patient. Let's get started with medication concerns in general. Many drugs prescribed and over the counter or combinations of drugs can cause cognitive problems or memory loss as a side effect. This is very common in older adults and with dementia patients. My husband's physician, Dr. Daniel Coffer, who used to be at UNC Memory Disorders Clinic before his death in July of 2020, told me that his best days in Memory Disorders Clinic were those days when he could remove a bad player drug from a person who'd come in being afraid they were going to be diagnosed with dementia. And just by removing that drug, the symptoms of dementia went away. Or by removing a drug for someone who was already diagnosed, some of the problems that they were having in their daily lives simply went away. So we have to really be careful when we look at the wide variety of medications that are out there. And we're going to be talking about that today. We're going to talk about something called polypharmacy to begin with. Polypharmacy is taking too many medications, because this can create cognitive problems, adverse reactions, and an unintentional overdose. Because some of the side effects of different medications can be similar. And when you have more than one of these medications that you're taking with the same side effect, that side effect may start to take over the person's life. And so we need to be very careful about taking too many medications. A number of studies have been done about this. One of them said that with 3 or more meds, there was loss of gray matter. And several studies do say that 5 or more medications can cause a loss of gray matter. We don't want to lose our brain material. We need to keep as much of that as we can, whether we have dementia or whether we don't. But in either case, this is a serious concern. So the more meds we take, the more medications we take, whether they're prescribed or over the counter, the higher risk we have for brain atrophy. Now, in the United States, people over 65 make up about 13% of the population, but we use 30% of all the prescription drugs. So recent studies do show a percentage of this age group taking 5 or more meds or supplements increased from 53 to 67% between the years of 2006 and 2011. So we have to assume that that trend may have continued going forward. When managing several chronic conditions, such as high blood pressure and heart failure, the use of multiple medications is often clinically necessary. But according to this article at uspharmacist.com, polypharmacy becomes problematic when the reason for the medication is unclear, the medications are taken to treat side effects of other medications, dosing and timing are complicated, or the medicines interact with each other in a negative way. Now, dosing and timing being complicated, let me explain that for just a moment. Let's assume that you have a patient who's just taking medicines in the morning when they get up, at breakfast time, and then before they go to bed. But another medication or two are added in there, which have to be taken every 6 or every 8 hours. All of a sudden, everything has gotten complicated. And so we've got to be very, very careful when these kinds of things are happening. Polypharmacy is an issue, but you need to be very careful that you do not stop taking medications without your doctor's consent. And you need to have conversations with your physician about any medicine that you think is a concern. We're going to be talking about a lot of those possible medications in this lesson that I'm about to give you. But you should also review your medicines with the pharmacist, because a pharmacist is a key member of your team. And they tend to look at things differently and from a different angle than the physician does. They're often very aware of drug interactions, much more keenly than a physician might be. And they are aware of who the best doctors in the community are. The ones whose patients tend to do better. They kind of get a feel for this over time. And so they see what those doctors tend to recommend or tend to diagnose or tend to give as prescriptions for those patients. And they watch what happens as a result. So these people are very important to add to your team. Now, a lot of what I'm going to be sharing with you, I want to put this book up as I get started. It's a pamphlet from the Lewy Body Dementia Association. Now, many of you who are watching this video are dealing with Lewy body dementia, and some of you are not. But this is still good information for dementia in general, even though a lot of it is very, very specific to and applies. All of this applies to Lewy body dementia for certain, but it also applies to many of the others. But this pamphlet called Diagnosing and Managing Lewy Body Dementia is written by physicians and for physicians. But you can get a copy of this for free by going to lbda.org, or you can go online and you can find a PDF copy of it. If you go to lbda.org and put in this title, Diagnosing and Managing Lewy Body Dementia, or you can go to the resources section and look for things like treatment or management. And this will be one of the options that should pop up for you. This is an absolutely excellent source for you, very, very trustworthy because it is written by physicians. The other thing about it I want you to know is that a lot of the material that I'm sharing today, the backbone of the material comes from this source. I wanted to make sure that what they said in here was included in this talk. I had a lot of other places that I drew this information from over years of working with physicians, working with a lot of dementia caregivers, where this list has basically been put together by me that kind of pulls a number of those together. But you will find this also in this book. So let's be careful for these with these classes of medicines: the anticholinergics, the benzodiazepines, the prescribed sedatives that are non-benzodiazepines, the antipsychotics, antidepressants, opiates, or the specific drug tramadol, which is given for pain, and then the anesthesias, the inhaled anesthetics in particular, and Versed I'm going to be addressing in this talk. Okay, let's talk about the anticholinergics. Anticholinergics are defined as a drug that inhibits the physiological action of the neurotransmitter acetylcholine. Now, I want you to pay close attention to this, and I'm going to be referring back to it later, much later in the lesson. If you are dealing with a drug that is inhibiting acetylcholine, you need to know that acetylcholine is the neurotransmitter that the dementia medication first line of treatment is the cholinesterase inhibitors, which help and assist and boost the action of the neurotransmitter acetylcholine. So if you're taking an anticholinergic drug, you're taking a drug that's blocking or interfering with the good medicine that your physician has probably described for you for many of the dementias, not all of them, but for many of the dementias, the anticholinergic medicine is blocking what your doctor is trying to give your loved one to help them. And so we want to be very careful about these, the medicines, all the medicines in this class, that we manage these in a very, very careful way, because we don't want to block acetylcholine in the brain. It's a neurotransmitter we're trying to boost, not block. Now, many drugs for many conditions are anticholinergic. And as we age, I want you to consider asking for a treatment for whatever your doctor is giving you that is less anticholinergic, or also ask for a non-drug intervention of some sort. Now, according to a Journal of American Medical Association article that was written in 2019, they found that there was a statistically significant association of dementia risk with exposure to anticholinergic antidepressants, anti-Parkinson, antipsychotic, bladder, and anti-epileptic drugs. And the associations observed suggest that these drugs should be prescribed with caution in middle-aged and older adults. So this is applying to us as caregivers as well as to those with dementia. So I'm just saying, if the healthy people who don't have dementia shouldn't be taking these, we should put up an extra flag of caution for those who do have dementia. We need to be careful with these kinds of meds listed in this article. Now, how do we find the anticholinergics? Well, we used to be able to look up something called the Beers list. And I just checked a little while ago, and I had a link up here for you, and that link no longer works. They have completely taken this off the public sector. And when they came out with the 2019 updated version of the Beers list, it was already really long in 2012. It's extremely long and involved in 2019. And they just simply have said they don't think they want it to be available to the public. So it's for physicians only and other people who deal directly with these medications. So we can't get to the Beers list anymore unless you have, someone who has a printed copy of that old 2012 one. But a place you can go to get a few of the names compared to what's on the Beers list is this People's Pharmacy site that I'm listing here in this link. When you get, it's a very good site, but when you get to it, you are going to have to scroll down quite a bit to find a list. And it's sort of in two parts, the ones that are of greater concern and the ones that are of lesser. And they'll tell you in the article, this is controversial. So all of this is, we are in the stage very much like the pandemic we're in right now. We're in the stage where we are learning as we go. And new information is coming on board constantly, but there are indications very, very clearly that the anticholinergic medicines are something that we need to stay away from as much as we can. I do need to give a caveat for absolutely everything and for each of these categories. And the caveat is this: if you've seen one dementia patient, you've seen one dementia patient. Based on a lot of factors, a medicine will work very well for one person that may be even counterindicated. And it will work very poorly for someone else and maybe even cause all kinds of extra problems that were avoidable. So we need to remember, sometimes these, even though they're on the bad list, sometimes they work. And for some people, they work. And so this isn't an automatic, no matter what, you don't do this. It's basically information that gives you a good reason to have a good conversation that's more informed with your loved one's physician. That's what this is all about. I'm not a doctor. I'm not a pharmacist. I'm just a person who has been a caregiver and has gotten involved in a lot of research. And I have a lot of network of people who are specialists and who are caregivers who have been involved in fighting dementia for years. And so I've learned this over time, and I feel very strongly about sharing it with any caregiver who's out there, because the more you know, the more you have a chance to help your loved one have a sweeter and a more gentle day. And avoiding these medicines in general is a good rule of thumb, but it doesn't mean that every single medicine is going to be a bad medicine for your loved one. It means you need to be careful. So let's go on. Some common anticholinergics. Probably the most common over-the-counter one is Benadryl, and its generic name is diphenhydramine, and it is going to show up in a large number of products. If you see products like cold medicines, allergy medicines with letters after it, there's a pretty good chance diphenhydramine is in there. and other medicines, if they have letters after them, like Tylenol PM, Robitussin DM, CF, all these different letters are going to show up. If they've got letters after them, don't give them to your loved one, because the chances are that something has been put into that medication that's going to potentially cause them problems. And the chances are quite good that that medicine that's been added is anticholinergic. So if your loved one has a cold or allergies and that kind of thing, just get the straight Mucinex, just get the straight Robitussin. Don't get the ones that have the letters after them. So brand names for diphenhydramine, the most common Benadryl. Also Somanex, Genahist, Unisom. So avoid the over-the-counter sleep agents. They are going to have products in them that are most likely unfriendly to your loved one's brain. The PM version of over-the-counter analgesics, the pain medications, Tylenol PM, nope, don't do it. Tylenol by itself, yes. Tylenol PM, no. So if it has letters after it, as I just said, avoid it. Overactive bladder meds like ditropan, Detrol are probably going to have anticholinergic properties. Flomax and Hytrin are not anticholinergic, so they're often going to be substitutes that you can put in there. Medicines for vertigo, motion sickness, or nausea, like Antivert and Phenergan, are anticholinergic, and they are very commonly given. Itching medications like Vistaril and Benadryl, muscle relaxants like Flexeril, and the tricyclic antidepressants, which we're going to talk about in a little bit, like Elavil and Pamelar. These are ones that are highly anticholinergic, and you need to avoid them. Okay, let's go in with the benzodiazepines. I'm going to say this in a minute. The benzodiazepines. They are prescribed frequently for anxiety. They're prescribed to help you sleep. They are habit forming. There is an increased fall risk with them, and they are associated with developing dementia. Common benzodiazepines are Ativan. I hear this name a lot when I talk to caregivers all over the country. Ativan is very addictive, and there's a very high risk of becoming dependent upon it. It can be very difficult to get off of. As a matter of fact, one of the sites that I'm going to share later has an explanation of how to get off, an in-depth explanation of how to get off Ativan. It's one of those bad players that Dr. Coffer talked about that he liked to take people off of because it so often caused problems. Halcyon, another bad actor, and it's very fast acting. Klonopin, which is one of the longest lasting and often more needed as time goes by. This is also known as clonazepam. I do need to speak about this one because for those of you who are dealing with Lewy body dementia, there is a core element to Lewy body dementia that many of the LBD patients have called REM sleep behavior disorder. And this medication used to be recognized as the first line of treatment to help with REM sleep behavior disorder. Dr. Carlos Schenck of the University of Minnesota discovered REM sleep behavior disorder with a colleague and has spent his career studying it. I spoke with him at a conference in New York City several years ago and got to develop a little bit of relationship with him and communicated and was able to ask him some very specific questions. And he and some other colleagues have come out with, in 2019, they came out with a paper where they had put a meta-analysis together of multiple studies. And they have reversed what their recommendation is. And they used to recommend Klonopin first with melatonin added. Now it is melatonin first from 6 to 18 milligrams, titrating up very slowly and under the care of a physician. And then if that does not work by itself, then you would add in the Klonopin, also known as clonazepam. So the reason they did that, they cite in the study, if you can get the paper online, I can send it to you if you want to email me. I'll be happy to share that with you. but they said the reason for that is melatonin is much less likely to cause bad side effect, whereas the clonazepam can do that. And so when it is added, they recommend it be added as a secondary treatment at a lower dosage or as an add-on treatment. So that's some interesting information. And this is an example where a common benzodiazepine like Klonopin is not recommended. But in certain situations, it's going to be something that might really help. It just needs to be managed in a certain way by a knowledgeable physician. Either he already or she already knows about it, or they're humble and willing enough to learn about how to do this properly. And all this information is available online. They should also see you as someone who's done your homework. When you bring these things up and you bring to them a way for them to look it up, if they didn't know about it, they should see you as a team member in this, because there is so much new information coming out all the time. No physician is going to be able to stay on top of all of it. Okay. Librium, Valium, and Xanax are other examples of commonly prescribed benzodiazepines. I want to tell a story about Xanax as well. This is when my husband John was diagnosed in 2007, shortly after. I was very stressed, and he and I had the same doctor. She's a wonderful, wonderful woman, and willing to learn all kinds of things about treating a dementia patient. But she was also treating me. And she said, Pat, I'm wondering if you need an antidepressant. And I said, well, I don't think so, but I'll try. I took one dose of whatever she gave me. I think it was Zoloft. And I just called her up and I said, you know what? My IQ dropped at least 20 points. I'm dull-minded, and I have to have as sharp a brain as I can have to take care of John. This is going to be a long haul. I do not want to be on this medication. And I think my issue might be more anxiety than depression. And she said, well, let's try Xanax, and I'll give it to you in a low dose. And you just try it. You know, break it in half if you need to. And it was like a 0.05, something like that. Very, very low dose. And I found that what I would do is, if I was really nervous during the day and I just had that kind of jittery feeling and I couldn't calm down by using other methods, then I would just break that Xanax in half and I would take it. At night, if I just couldn't sleep, I would take the whole pill, but it was a very low dose. What I found, though, over time was if I did that 2 nights in a row, it was like, all right, but if I did it a third night, if I went past 2 times in a row, I started thinking, my body kind of needed that Xanax to go to sleep. And I'm like, uh-oh, not going to do this. And so I learned that I would not take more than 2 of these at one time. And this was how my body was processing it. And what I found with the Xanax was that it helped me being on the shelf of my medicine cabinet. I knew that it was there if I needed it. And so I could just not get overly stressed. If I was feeling some anxiety, I could just kind of do my deep breathing. I could do the yoga. I could do the aromatherapy. I could go get a massage. I could do those things that were non-pharmacological and usually calm myself down. I knew that medicine was there 24 hours a day, just waiting in case I needed it. So it helped me by sitting in the medicine cabinet. And I didn't ever use it any other way than that. And so it was very, the doctor told me, she said, Pat, you're using the Xanax exactly the way the Xanax was designed to be used. It's a PRN. It's use as you need it. Use as needed, not taking it constantly all the time. Steady, steady, steady. That's when you can get into trouble. And one of our slides is going to be talking about that. Here it is right here. In 2019, the National Institutes of Health did a meta-analysis that pooled 10 studies, and it showed that benzodiazepines significantly increases the risk of dementia in the elderly population. The risk is higher if the medicine has a longer half-life, and you'll have to look that up online, and if it's given for a longer duration, greater than 3 years. See what I mean? We're not supposed to get on these things and stay on these things. We're supposed to use them for a short duration and then we let them go. So we have to be careful that we are managing our medicines as well as our loved ones, and the medicine is not managing us. Okay, where can you find a benzodiazepine list? Wikipedia actually has a good list, a fairly decent list there, and it has common trade names and the therapeutic uses, which I like very much, because that way you can really get a clearer picture and an understanding of what medicine you are dealing with and for what reason. Now, there are sedatives that are prescribed that are non-benzodiazepines for people who are having trouble sleeping. Ambien, very, very common. And it's one of those that Dr. Coffer talked to me about. The three that I heard about the most and that I hear about the most nationwide talking to people are Haldol, and that's not in this category, but the three bad ones that I hear about the most are Haldol, Versed, which I'll be talking about later. Actually, there's more than that. Ativan and Ambien. But the ones that are in these categories right here, the Ambien, the Ativan, and the Benadryl, those are the three that tend to get prescribed commonly to a lot of us, whether we have dementia or not. And they are bad, what I call bad news in shoes. You just need to stay away from these medicines if you can. They grab hold of you. It's hard to let go of them. And they just drain, I call them brain drainers, a very non-medical term, but for me, it makes sense. They're draining my brain. I don't want to hang around with these meds. So the particular ones we're talking about right now, the non-benzo prescription sedatives are Ambien, Sonata, and Lunesta. Notice that each of them has a Z in it. Here again, I tried to find simple ways that would help me go, whoop, is this a flag? The letter Z is in each of these. So if I saw the letter Z in a medicine, I would go, I better look that one up. That's one of the Z's. I better be careful with that. Is it going to work for you every time? I don't know. But I use little tricks like that to help me navigate, because there was just so much going on in dementia caregiving, and you get so weary, and you need sometimes little easy rules of thumb that will kind of help you avoid some bumps in the road. All of these medicines are shown in studies to impair thinking and balance in the short term. So think about it. Do you want to impair thinking for yourself or your loved one with dementia? Do you want to risk them getting up in the middle of the night with a balance issue? Is that wise? No. So that's why you want to avoid these if you can. Okay, we're going to go to another category, the antipsychotics. These are usually prescribed to manage difficult behaviors related to dementia. They may be for a serious mental illness, and they can be sedating, and they can dampen brain function. In older folks with dementia, they are linked to a higher chance of death. Antipsychotics are associated with falls, and alternatives should always be explored. Use these as a last resort and at their lowest effective dose. We have a rule of thumb when we teach the dementia caregiver class, and that is with medications. There are two rules of thumb. One, only make one change at a time. Never take away and give a new medicine at the same time. Give a gap in between of a few days. Never give two medicines at the same time. Give a gap in between. So one change at a time. That way, if something goes haywire, you have only one variable to look at in terms of medication. And the second rule, very important, start low, go slow. So you want to start at a low dose and then titrate up slowly. And then if you have to take them off, you titrate down slowly. So low and slow is very, very important. Another thing about antipsychotics is if you can use the non-pharmacological approaches to try for behavioral issues, to keep things as stress-free as possible, as calm as possible. I think it's very, very important that we think about what we bring into the room as caregivers. that is non-pharmacological, but very powerful. What is the look on our face? What is our body language showing? What does the tone in our voice say? How about the speed of our speech? Could we use things like aromatherapy in the room? Things like lavender to calm things down? Soft music or favorite music in the background played so that it doesn't interfere with speech or when there's not a lot of speech happening? Are there things that we can do in terms of setting the mood and setting the tone? Are there ways we can ask questions that involve fewer words and limit the choices to one or two things? All kinds of techniques like that that cost nothing, but make a huge difference, that may keep stress at such a level that behavior that might have been there doesn't show up. And there's one more thing that's very powerful that I want to put in here, and that is the tremendous power of total forgiveness. If you are walking into a room with the person that you love and you're caring for, and there is an unforgiveness, a resentment, a buried anger in you, in your heart to that person, it's going to show up sometimes. And so a radical, total decision to forgive that person, just forgive them, let it go, will liberate you from walking in the room with that. It will liberate them from throwing back at you what you're going to get when you walk into the room with that. And it will create a completely different environment, and it will make things much easier. So there are all kinds of non-pharmacological things you can do. These are just the ones off the top of my head that I know were very, very important at my house and that made a massive difference. I am positive in the kinds of days that we had, because those choices were game changers. You're going to have stuff that you are holding against. If you've been married to somebody for 20 or 30 or 40 or 50 years, you're going to have some stuff in there, because no two people can live together and never, ever hurt each other. That's just not possible. So let's get real about that stuff and let it go. Give you a much easier time of it. Guarantee you. Okay, what are the antipsychotics we need to avoid? The typical antipsychotics, which are also called neuroleptics, the atypical, and they're older ones, the atypical antipsychotics, especially those with a high D2 receptor antagonism, such as olanzapine or Zyprexa or risperidone or Risperdal. You need to avoid these if you can. This is particularly true for LBD patients. Now, for some people, they're going to work just fine. Just like I said, if you've seen one, you've seen one. But as a rule of thumb, this, particularly if LBD is in your story, you need to stay away from those. What are the commonly prescribed typical antipsychotics? Now, here's a long list here, but I'm going to talk particularly about the one at the top, all in blue, Haldol. I describe this as the worst curse word in the English language. You never, 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 never want to allow your loved one to be given a shot of Haldol. And that can happen in an ER before you know it, can happen in a hospital setting, it can happen in a nursing home. So you've got to be very careful to list Haldol as something they're allergic to. That's what I would recommend that you do. They cannot have it. It can kill them or worse. And I know some horror stories that I don't want to share with you because they'd frighten you. Awful, awful things that can happen to people who get a shot of Haldol. And this is pretty much for any dementia, but most definitely for Lewy body dementia. So that is a total no-no, nasty, nasty, awful word. Okay, there's another list here of things that are commonly prescribed that are typical that you want to avoid if you can. Here are some commonly prescribed atypical antipsychotics: Abilify, Geodon, Risperdal, Zyprexa. Now, you've seen them come up before. And so we need to be really careful with those. Here again, some people may respond to them, but they are ones that are generally not recommended. For LBD patients, Seroquel is kind of the go-to antipsychotic, the quetiapine. Even with the Seroquel, you're going to have about half the LBD patients respond beautifully to it. You're going to have the other half see it as a nightmare medication. My husband took one dose, the lowest level, and had a full-blown 4-hour psychotic episode. And we knew, oh, Seroquel's not going to work. We're not going there. And so here again, the clozapine, same thing, except you're going to have blood tests with that. So usually they go to the Seroquel first. But these are things you need to be very careful. And notice it says low dose for psychosis. You try not to put too much in there. I do know of a good number of stories where somebody was given Seroquel who was having some behavioral issues, and they didn't get any better. And so the doctor said, okay, well, then he didn't give them enough. We got to give them more. And that can also backfire. The other thing that can happen with the Seroquel that you need to be aware of is that it works beautifully for a season of time. And then remember, the brain, dementia is a brain failure disease. It's not just a memory disorder, it's full brain failure. And so as the brain is shrinking, as it's degenerating, which a lot of dementias are degenerative, most dementias are degenerative, then what you've got happening is the brain is shrinking, the neurotransmission is getting worse. And so there may come a time when the Seroquel no longer is functioning the way it did originally. And you need to be aware of that. If that's in your story and things are starting to go a little haywire, that may be a medicine that you have a conversation with the doctor about, that, you know, it did work, but with things changing the way they have, could we try, backing off on that a little bit and see if a lower dose or maybe removing it could make things better. I know a good number of stories where that has happened. So be aware, there's always the dance. There's always the tweaking that has to go on with medications. Okay, let's look at antidepressants. Antidepressants are medications that are used to treat major depressive disorder, some anxiety disorders, and some chronic pain conditions. You should avoid the tricyclic antidepressants. I mentioned this earlier in the lesson. Tricyclic antidepressants increase the levels of norepinephrine and serotonin, which are two neurotransmitters, but they block the action of acetylcholine, which is the neurotransmitter that you were taking either Aricept or Exelon to boost. Think about that. You don't want to take a medicine that's going to block the very neurotransmitter that you're trying to enhance and boost. That's why you need to avoid the tricyclic antidepressants, because they want to block acetylcholine. Now, here are some safer depression treatments. The SNRIs, and you see the examples there. The SSRIs, and you see multiple examples here, are the safer way to go. Once again, start low, go slow, and watch for negative side effects. Now, what about medicines for pain management? Opiates or the medication called tramadol should be avoided if possible. Alternatives for pain management include the non-steroidal anti-inflammatory agents like ibuprofen and acetaminophen or Tylenol. Remember, you don't want to take Tylenol with any letters after it. And you should take these medications with food because that protects the lining of your stomach. This is a good website for managing your medications. It's based in Canada and there's a lot of information on it. And I think this is the website that has the how to get off Ativan in great detail. It even gives you a daily chart of what to do if that's something that you're needing to do, because you can't just pull these things away safely. You don't want to create another problem by doing it wrong. And you should always, as I'm saying, always discuss this with your doctor. What I'm doing in this lesson is giving you good information for better conversations with the physician. The physician needs to always be in the loop on this. Okay, what about surgeries? My nickname for any surgery now, I didn't used to know this before, but I had to learn, is the triple whammies. Oh, surgery's the triple whammy. You get pre-surgery meds, which are typically benzodiazepines. You get anesthesia choices, which may be inhaled anesthesia, or something called Versed, which makes you forget what happened. Now let's stop and think about that. Do you want something giving your loved one who has dementia amnesia? Do you want the memory part of his brain messed with by the choice of anesthesia? I think not. And I know many, countless, as a matter of fact, stories about what happens to people who get Versed. You need to stay away from Versed. Now here again, your loved one may take it and it may not have an impact, and that would be wonderful, but you've got to be very careful. And inhaled anesthesias typically are not good for dementia patients. Post-surgery meds are for nausea. That's one of the things that they're looking at and trying to help you with. And so they're going to be anti-nausea meds. Remember how we said that the classic one, Phenergan, for that is not good. And so you can typically have one, or you should ask for one that has less qualities of anticholinergic qualities. So here are your options. For the pre-surgery option, ask for a lower dosage for the relaxant. For your anesthesia option, ask for propofol if it's a short-term surgery. Or for a local anesthesia, if possible, like a spinal block. These kind of alternatives can be much more brain-friendly than, say, the Versed or the inhaled anesthesia. For post-surgery, to treat nausea, ask for a lower anticholinergic choice. And they're out there. I think Zofran is one of the most common ones that are used. Okay, here's my last slide. And the simple way to know is just Google it. Google the drug name and then a word like anticholinergic or benzodiazepine. You want those names to pop up so that if it does have those, it's in that category or it has those qualities, you will see it. You'll be able to see when you're reading about the drug that it is that type of drug. Or you can put in what type of antidepressant is and the name of that drug, or what type of medicine is, or what type of drug is, and then the name of that drug. And that will help you learn more about whether or not it's in one of the classes of drugs that we recommend. I want to thank you for what you are doing. You learned a lot in this lesson. It is jam-packed full of big, confusing words. I hope you will feel free to go back and go to those slides that you need. Take screenshots of them with your phone. Go do your own research. And I hope you will have wiser and deeper and more knowledgeable and informed conversations with your loved one's doctor as you move forward and as you are trying to just be the best you can be at this caregiving game. I thank you very much for your time, and thanks for all you do every day as a caregiver. God bless you.